Okay, great. Thank you, Randy. Welcome, everybody. I am very pleased to introduce to you Dr. Ahmad, who is here to talk about cardiomyopathies. Dr. Ahmad's our Director of Cardiovascular Genetics Program at the University of Iowa, which brings together basic scientists at the Carver College of Medicine and clinicians at the University of Iowa hospitals and clinics who are focusing on heritable cardiovascular disorders. Dr. Ahmad directs the laboratory conducting basic and translational research into the genetic and genomic mechanisms underlying inherited cardiovascular disorders, including hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic RV cardiomyopathy, glycogen storage cardiomyopathy, various inherited arrhythmias, pulmonary hypertension, and others. His laboratory uses a wide range of techniques in human, mouse, pig genetics and genomics and fosters crosstalk between clinical studies, human molecular studies, animal modeling, basic cellular and molecular studies, and computational biology analyses. So in the University of Iowa Hospital and Clinic's Cardiovascular Genetics Clinic, Dr. Ahmad leads an interdisciplinary team that evaluates, counsels, and treats patients with various inherited cardiovascular disorders and also counsels their families as needed. And with that, I would like to introduce to you or to turn it over to Dr. Ahmad.
Oh, thanks, Denise. I appreciate your inviting me to speak today, and certainly appreciate the audience joining us, especially since AHRS is also on right now. I'm going to go ahead and share my PowerPoint. Okay, can everybody see my slides here?
Yes, looks great.
Great, okay, wonderful. So before I start, I just want to mention that I do get some research funding for some basic science work from Bristol Myers Squibb. But what I'm going to talk about today is unrelated to any work I'm doing with BMS. So what I'm going to talk about today is discuss some of the genetic basis, the genes involved in various cardiomyopathies and neuromuscular disorders that affect the heart. And then for this audience, you're particularly interested in how you risk stratify patients for sudden cardiac death and decide who might benefit from an ICD. So we'll spend quite a bit of time on that topic. In certain situations, patients require permanent pacemakers, and we'll discuss those sort of niche areas. And another important point for some of the disorders I'll discuss today is that anticoagulation for atrial fibrillation does not follow the usual sort of CHADS fast scoring system, and we need to be aware of that. All right. I think Dr. London's talked about the basics of Mendelian genetics, so I'm not going to spend a whole lot of time on this, but the most common patterns, there's several patterns are on this slide. Probably the patterns that we face most often are autosomal dominant, in which either males or females can have the disease. You require just one abnormal or mutant allele of a gene that's associated with disease to get the disease. So in this case, the father here has one abnormal allele and one normal or wild type allele. The mother here has just two normal alleles. And each parent randomly will pass on one or the other allele to their children. So on average, in this family of 4 children, 2 of the children, one son, one daughter, have inherited the abnormal allele from the father, and they are at risk of developing the disease. In the autosomal recessive pattern that we see sometimes, one abnormal allele is not sufficient to cause the disease. You actually need 2 alleles to be abnormal, both of the genes, or both of the copies to be abnormal. So in this case, both the mother and the father are actually carriers. They have one abnormal allele, but one normal allele. So they don't actually have clinical disease. But when they randomly pass on one or the other allele to their children, this child, on average 1 in 4 children, will get both abnormal alleles from either parent and can develop the disease. On average, about 50% of the kids will have only one abnormal allele from one or the other parent, and they will be carriers, but they won't have disease. And then this child is the luckiest because in this case, a girl, she didn't get either abnormal allele, so she's completely normal. We do also see X-linked recessive patterns of transmission. So in this case, for example, the gene that causes disease is on the X chromosome. And of course, females have 2 X chromosomes, and males have only 1 X chromosome. In this case, the mother has 1 abnormal allele, but because it's a recessive disorder, she is basically a carrier. She doesn't actually have disease. Now, she can pass on either allele to her children. In this case, she passed on an abnormal allele to one of the sons. And since the son got, because he's a male, he got the Y chromosome from his father, he actually has just 1 abnormal allele, so he gets disease. This daughter got the abnormal chromosome or abnormal allele from the mother, but she got the normal X chromosome gene from her father. So because it's a recessive disorder, the normal allele here compensates for the abnormal allele, and she's a carrier but doesn't have disease herself. All right. So what we're going to discuss today are a number of different cardiomyopathies and cardiac manifestations of neuromuscular disorders. Many of them are pretty common. As you'll see, hypertrophic cardiomyopathy may be present in the population at up to 1 in 200. That is to say, about 1 in 200 people have a mutant allele or some sort of genetic variation that can lead to hypertrophic cardiomyopathy. We'll also discuss phenocopies or mimickers of HCM that kind of look like HCM, but they're very different, and that's important to realize. And then some of the other cardiomyopathies like noncompaction, dilated cardiomyopathy, and arrhythmogenic cardiomyopathy are less common, but still quite important in the population. The neuromuscular disorders are generally less common, present maybe anywhere from 1 in 5,000 to 8 in 10,000. We'll discuss the myotonic dystrophies and the dystrophies. It's too early in the morning today, but Duchenne and Becker muscular dystrophy. All right, so let's start with hypertrophic cardiomyopathy then. As you all know, it is manifested by abnormal thickening of the myocardium, especially the ventricles and the septum. And you can have many different patterns. You can have predominantly septal hypertrophy, but you could also have more sort of concentric hypertrophy all over. You can have apical hypertrophy. And even in the same family, patients with the same genetic variant can have different patterns. So there's no rhyme or reason as to what kind of pattern an individual patient may have. And histologically, the normal myocardium with nice myocytes laid in parallel are kind of displaced. So here you get myofibrillar disarray. The myocytes are no longer kind of nicely organized. And on a mass spectrometry staining, you see a lot of blue, which is indicative of collagen or fibrosis, which is a hallmark of hypertrophic cardiomyopathy. Now, it's actually very predominant or prevalent in the population. Maybe 1.5 million people in the United States have HCM. Only about 20% actually know they have it, and most patients actually do fine. It's not a particularly lethal disorder for most patients. The annual mortality rate is about 1%, which is about the same as the general population. But there are some subgroups that are high risk of mortality and particularly sudden cardiac death. And so that's where our job is to try to figure out who's at high risk of sudden death. And unfortunately, a lot of young folks can die from HCM, and we want to protect them from that adverse outcome. We will focus mostly on the electrophysiological issues here, but there's many different clinical aspects that we have to just kind of look at in patients with HCM. Certainly, many of them can be symptomatic because of outflow tract obstruction, where you have septal hypertrophy that impinges on outflow of blood from the left ventricle into the aorta. And there's a variety of medications, including some newer ones that are under FDA consideration right now that are helpful. And if the medications fail, then you have to often resort to septal reduction therapy in patients that are severely obstructed and symptomatic. In terms of our topic today, we have to figure out who's at high risk of sudden death. And we also have to know how to treat atrial fibrillation and reduce the risk of stroke in these patients. The genes that are associated with HCM are multiple, but the general theme here is that most of these genes encode proteins that are either in the sarcomere or associated with the sarcomere. So basically, they are HCM is kind of a disease of the sarcomere, and that's probably the theme that you really need to remember. In terms of the pathophysiology, we've actually made considerable progress since the first genes were identified around the turn of the century, or a little bit earlier. And so what happens is that, as you know, the sarcomeres are composed of interdigitating thin and thick filaments. The thick filament is made up of primarily myosin, the thin filament primarily actin. And there's a head that comes off the myosin thick filament that connects to the thin filament and kind of pushes the filaments past one another during systole. Now, in the sort of diastole, in the relaxed state, there's actually two states that the myosin head can be in. One is called the disordered relaxed state, and the other one is the super relaxed state. And there's kind of an equilibrium in normal myocytes, an equilibrium between the two states. If the head is in sort of this disordered relaxed state, then it can actually latch onto the thin filament and interact with it. What happens with a lot of variants in HCM, they're in this area of the myosin head. And this particular domain is what's responsible for keeping the head in the super relaxed state. So when that is disrupted, there is a shift in the equilibrium to the disordered relaxed state. And that state can allow for interaction between the thin and thick filaments. And so this is kind of a gain of function issue where the sarcomeres are overactive. They can be hypercontractile, and you can also have impaired relaxation. And so clinically, that's kind of what you see. Often these patients have a supraphysiological ejection fraction, and they also have diastolic dysfunction. All right, so in terms of how we figure out who's at high risk of sudden death, there's been some evolution of thought, and the most recent guidelines for hypertrophic cardiomyopathy from the AHA and ACC just came out late last year. They're similar to what we have looked at in the past, but there's some nuances here. You want to look at risk factors like obviously a personal history of cardiac arrest or a sustained ventricular tachycardia, or syncope that is probably arrhythmic. And so in these situations, you would consider an ICD quite strongly. Family history of sudden death, extreme cardiac hypertrophy, an ejection fraction of 50% or less. We'll talk about this in a minute. Apical aneurysm, we'll talk about this as well. And then just non-sustained VT on Holter monitoring. So these are some of the risk factors you look at. You can also do a cardiac MRI that might help you in decision-making, and we will talk more about that in a minute. And a couple of other parameters you may want to look at are the LA diameter on echo and the severity of the LVOT obstruction. And again, we'll discuss this in more detail. So why are apical aneurysms such a problem? So it turns out that many patients can develop apical aneurysms, especially those that have the apical variant with apical hypertrophy. And these patients seem to be at high risk of adverse events here in blue compared to red here, which are patients without aneurysms, especially arrhythmias and thromboembolic events. So many of these patients you would strongly consider an ICD and potentially anticoagulation to prevent thromboembolism. The other issue that we are really becoming more cognizant now of is that ejection fraction deterioration is a significant risk factor for death and other adverse outcomes, sudden cardiac death and all-cause mortality. You'll see that here where patients that have an ejection fraction of 50% or less are at much higher risk of sudden death, just any kind of HCM death or all-cause mortality. And they're much more likely to end up getting transplants as well. And the cutoff is 50%. And you might think, well, 50% isn't terrible. And this, you have to go back and remember that I told you that HCM is a gain of function disease. It's a disease of hypercontractility. So their baseline is actually very high. And if they're getting down to 50%, that's kind of like maybe 30% in somebody else. And so they are actually, by the time they get to 50%, they're actually at high, they're basically like the end stage heart failure, and they're at high risk of mortality and other adverse outcomes. So these are sort of the recommendations right now from the guidelines. Obviously, for secondary prevention, a patient will need an ICD. For primary prevention, again, you will look at massive LVH, and there isn't a, traditionally we use around 3 centimeters as a kind of a guide as to what is severe. Of course, it's not a binary situation, and there's a gradation of increased risk with increased hypertrophy. Family history of sudden death, unexplained syncope, aneurysm, and ejection fraction less than 50%. These are all sort of class 2A indications. If you have just NSVT in the absence of anything else, just on a Holter, there is, that's a gray zone, at least in adults. If you find a lot of late enhancement or fibrosis on cardiac MRI, that also kind of increases the risk and puts you at least into the intermediate area. Now, how can you kind of make a decision as to whether to place an ICD in a patient? You can also use a risk calculator that has been validated and it's kind of been promulgated by the European Society of Cardiology. There are a number of apps on phones that are available, or you can go to websites and just enter a number of parameters: the age of the patient, their maximal wall thickness, their LA size. So that's what I was referring to before. The severity of LVOT obstruction, and then family history, NSVT, syncope, EF less than 50%, apical aneurysm, and fibrosis. So late enhancement that is at least about 15% of the ventricle. All these are entered in, and then the calculator will spit out a 5-year risk of sudden death. Generally, we say that if the risk is more than 6%, then an ICD is indicated. If it's less than 4%, an ICD probably is not indicated. And again, if your risk is around 4 to 6%, then it's sort of again a discussion between you and the patient and shared decision making. What about exercise? Patients are quite concerned about what exercise they can do. So this is sort of a matrix that was established by the AHA and ACC for different forms of sports and exercise based on both dynamic and static exertion. What is recommended is that if a patient has clinical evidence of HCM, that is to say they have a phenotype, then they really have to limit their activity to class 1A types of activities. If, on the other hand, we're seeing more and more patients now that we're doing a lot of clinical genetic testing that are genotype positive. They have a variant that causes disease, but they have no clinical evidence of disease. In this case, right now, the recommendations are that they can do whatever kind of activity they want. Again, we don't have tons of data or any of this, but those are kind of our recommendations right now. The European Society of Cardiology has slightly different guidelines, and this kind of indicates that we really don't have great data yet, so a lot of this is still kind of opinion, but they're saying that if a patient has clinical evidence of disease, then avoid high intensity exercise if there are certain markers for high risk, but otherwise they're not actually prohibiting high intensity exercise. But like the ACC and AHA, they do say that in genotype positive, phenotype negative patients, there are no restrictions. How often do you need to keep following these patients and re-stratifying them? Generally, if they have evidence of disease, then every year, or at most every 2 years, they need some sort of clinical assessment, echo and Holter. And then less frequently, depending on their symptom status, they may need stress echocardiography, CPAT echoes, or repeat cardiac MRIs as well, just to see whether their risk of sudden death has changed. What about situations where a family member has been diagnosed? In that case, the recommendations for children are that if they're in a family that has early onset of disease, or if you have a genetic variant that's been identified in that family, then the children need to be screened at that time. And then if it turns out that they, of course, don't have the genetic variant, or there's no clinical evidence of disease, then they should get rechecked every 1 to 2 years. In all the other children, you can probably, you need to screen them at some point, but no later than puberty, and then rescreen them every 2 to 3 years. In adults, again, if they have no evidence of clinical disease, but they have a genetic variant, or you just don't have a genetic variant at all in that family, you haven't identified anything, they need to get rescreened every 3 to 5 years. When might you use pacemakers in HCM? The main area, the main issue would be in patients that are undergoing septal reduction therapy. They are at higher risk of developing bundle branch blocks. And if they only have an underlying block, then these procedures can cause complete heart block. So you need to be cognizant of that. Now, these patients are also at high risk of atrial fibrillation. And there's many potential reasons why that might be happening. One is just that the myopathy that's happening in the ventricles is also happening in the atria. So the incidence of atrial fibrillation in this population is about 3% per year. And if they're not anticoagulated, then their risk of strokes is about 4% per year. So it's really high. And this is a situation where it doesn't really matter what the CHA2DS2-VASc score is, because it's not really validated in this population. Any patient that has had atrial fibrillation, even if they're back on sinus, even if they're on potentially antiarrhythmics, they need to be anticoagulated for life unless there's a strong contraindication. And generally, we are now using DOACs as first-line therapy. We used to use warfarin, but DOACs seem to be as good or better in this population. So that's kind of what we start with. And then, there's other considerations about, who you might offer other forms of therapy. You may just opt for rate control if you're not able to keep them in sinus, along with anticoagulation. Or you may try to ablate them. Success rates are not the greatest, but sometimes they do work, at least for a time. And then antiarrhythmics are an option as well, with all the potential side effects that you're aware of. All right, another area that you need to be aware of is that there are a number of diseases that are genetic that kind of look like HCM, especially on echocardiography, but they're not HCM. And here's where we have to be a little careful about sort of the terminology we use. We often tend to just call everything that looks like hypertrophy on echo as and is genetic as HCM. And that's probably a dangerous thing to do. HCM really should be limited to those patients that have sort of typical sarcomere gene mutations. But there are a number of other sort of systemic or metabolic disorders that are genetic that can cause cardiac hypertrophy, but they have very different pathophysiology and a very different treatment. Here's some examples of different mimickers of hypertrophic cardiomyopathy. Some of them you kind of do treat just like sarcomere HCM, but there's others that are distinct. And I won't have time really to go through every one of these in detail. But let me give you an example of sort of a distinct disorder that you have to treat differently. Let me just skip through that one. Okay, so we got a mimicker. Actually, as a graduate student involved in the discovery of this gene. So this is a gene called PRKT2, which is encoding this gamma 2 subunit of this heterotrimer called AMPK. AMPK is a kind of a cellular fuel gauge that turns on when a cell is energy depleted. And one of the things it does is it increases glucose uptake into the cell to increase ATP levels. The gamma subunit that's encoded by PRKT2 is sort of the cardiomyocyte specific gamma subunit. It's a regulatory subunit. And it turns out what it does, well, I think I should say, this is quite different from the sarcomere genes that we traditionally associate with HCM. And so what these variants in the gamma subunit do is another gain of function. They cause the AMPK to be overactive. The cell is told to bring in glucose that it actually doesn't need. And so that glucose gets stored as glycogen inside the cell. And this is kind of what you see on histology from patients with this disorder. You get these vacuoles in the cardiomyocyte that are just full of glycogen. Another thing that happens is, this is from a mouse model that we worked with, is that the annulus fibrosus that separates the atria from the ventricles is disrupted by glycogen. In this case, in these mice. And we think that's the reason why these patients are actually predisposed to pre-excitation as well. This is sort of typical findings of a patient with this disorder. You'll notice that there's evidence of LVH on ECG, but also note the short PR interval because of pre-excitation. hypertrophy on imaging, and fibrosis as well on cardiac MRI. This is a disorder that we kind of just discovered, through genetics, about 20 years ago now. So we still don't know a lot about it. This is a case series from Europe, about 90 patients that have mutations in this gene. Initially about 26 did not have any clinical disorder, but 64 did. They were followed for a median of about 6 years. 4 of these 26 patients ended up becoming affected during that time. And then even among the 22 patients that didn't have evidence of clinical disease, there were 5 deaths. And then amongst those that had clinical evidence of disease, there were quite a large number of deaths and heart transplants, and just heart failure in general. Many patients had atrial fibrillation. A few patients had sudden cardiac death. A lot of patients became pacemaker dependent. So another thing that happens is probably the glycogen is somehow impinging on the conduction system, and many of these patients end up pacemaker dependent. So who do you put an ICD in? Again, we don't have a lot of data. We don't have any guidelines on this, but generally, you would, if a patient has a history of syncope or documented ventricular tachycardia, or a bad family history, or severe heart failure with EF less than 35%, then probably those would be appropriate patients for an ICD. In terms of pacemakers, these are just from the standard guidelines. They're the only issues you kind of have to think of specifically in these sort of infiltrative cardiomyopathies is that Mobitz type 2 blocks, high-grade blocks, third-degree blocks, standard sort of reasons that you might consider a pacemaker would be appropriate in this population as well. All right, let's move on to dilated cardiomyopathy. So this, again, as you all know, is manifested by abnormal dilation of the ventricles and poor systolic function. And the genes that are involved are actually multifold. So you'll see that many of the genes are still the same sarcomere genes that we saw for HCM. In addition, though, there's many other genes, including desmosomal genes and nuclear envelope and cytoskeletal genes. And the mechanisms by which they lead to dilated cardiomyopathy are probably diverse. But one curious thing is why do sarcomere genes cause DCM when they also cause HCM? And the reason is that, and I kind of told you that the HCM mutations cause a gain of function in the sarcomere. Turns out that the variants in the same genes that cause DCM actually are associated with the loss of function of the sarcomere. And that's why you get this different phenotype. So I guess the $1 million question is, when do you put an ICD in these patients? Traditionally, we have used the same criteria for ischemic heart failure as we do for sort of non-ischemic or dilated cardiomyopathy. And there has been some degree of uncertainty in the literature. I think most of you are aware of the Danish trial that came out a few years ago. And what they found is that in the non-ischemic dilated cardiomyopathy population, there was no difference between the control and ICD group for just death from any cause or all-cause mortality. Although in younger patients, there was a benefit for all-cause mortality. And similarly, there was a trend towards a decrease in cardiovascular death, but not significant. There was a significant difference in sudden cardiac death, at least, but not in the other sort of endpoints. And there have been a number of other trials, which again have been a little bit equivocal, but there have been several meta-analyses of all the trials, and they do suggest that there is actually a reduction in all-cause mortality in the non-ischemic population. So for now, our recommended practice is that you still follow the same criteria for dilated cardiomyopathy as you do for the ischemic heart failure population. And so you all know this, but secondary prevention, of course, you have a cardiac arrest survivor, you can offer an ICD, but the other indications of primary prevention include basically patients with class 2 and 3 symptoms, and an ejection fraction of less than 35%. There are some other nuances too. So, patients with bundle branch, especially left bundle branch block pattern and wide QRS, might benefit from CRT-D. The other situation is that if patients have conduction abnormalities and you anticipate that they will actually end up reporting a lot of ventricular pacing, then you may consider sort of a CRT device to help prevent worsening of the ventricular function. There's one other caveat in terms of the genes involved. If there are certain genes that seem to be the cause for dilated cardiomyopathy, those patients seem to be at higher risk of sudden cardiac death. So you may actually modify your criteria a little bit for them. The genes that are associated with high risk of sudden death include lamin AC, filament C, RBM20, phospholamine, desmin, and SCN5A, which, as you know, is associated with long QT syndrome and Brugada syndrome, but can also cause a dilated cardiomyopathy phenotype. So in those cases, you may not want to wait for the EF to drop to 35%, and especially if there's some other concerning history like syncope, family history, documented NSVT, you may actually offer an ICD even if the EF is better than 35%. What about exercise in this population? So, the ACC and AHA kind of, again, say that you should limit, if you're symptomatic, limit your activity to class 1A sports on that matrix. The ESC is a little bit more liberal, and they're saying low to moderate exercise if you don't have any significant symptoms or ventricular arrhythmias associated with exercise. All right, let's move on to left ventricular non-compaction cardiomyopathy. So you know that this cardiomyopathy is associated with deep trabeculations in the ventricles, especially the left ventricle, but it can actually be biventricular. And this is actually associated with heart failure in many patients as well. The genes involved, again, it's kind of the same, the usual suspects are coming up again, a lot of sarcomere genes. And it's kind of curious because sometimes the same patient can have both an HCM phenotype as well as a non-compaction phenotype, or you can have patients in the same family, some are predominantly HCM and some are more non-compaction. So we really have to figure out what the pathophysiology here is, but it's clear that there's some sort of connection between these different cardiomyopathies at the genetic level. As I mentioned, high risk of heart failure, high risk of atrial and ventricular arrhythmias and thromboembolism. The risk of any major cardiovascular event is about 8 to 9%. So it's quite substantial in this population. How do you manage these patients? So this I've kind of adapted from Steve Ahmed at Mayo Clinic. If the systolic function is still normal in the patient, then for sudden death, you kind of use the same criteria as you use for HCM. If, on the other hand, they also have a low ejection fraction, then you kind of combine the HCM and the DCM criteria to decide who might need an ICD. There are no sort of real guidelines for non-compaction per se. Overall, all they're saying in the ICD guidelines is, it's a class 2B indication to put an ICD in anybody with non-compaction. So it's not particularly helpful. We can kind of tweak it a little bit. I think that if there's a family history of sudden death, if there's documented VT, if the EF is less than 35%, if there's probable arrhythmic syncope, then those patients definitely you want to consider an ICD in. The other thing is, there's a little bit of uncertainty what ejection fraction counts, but generally for me, at least in my practice, if the EF is less than 40%, then you will offer anticoagulation to those patients. For exercise, again, it's, if they don't have any significant symptoms or risk, then you may consider allowing them to do competitive sports. Otherwise, you should limit them to class 1A sports. And for anticoagulation, again, the risk of embolism is quite high. And so especially if they have a prior history of embolism or atrial fibrillation, or if the EF, as I said, is less than 40%, anticoagulation is probably appropriate. All right, let's move on to something called ARVC. And this entity actually has multiple names that have evolved over the years. I'm still going to use this term, and I don't have time to get into the debate about what the appropriate nomenclature is, but whatever name you use, this cardiomyopathy is associated with replacement of the myocardium by adipose tissue and fibrous tissue. And that creates this arrhythmic substrate. And patients can develop heart failure because you're getting progressive replacement of the myocardium by non-contractile tissue. And as the name implies, there's a high risk of arrhythmias and sudden death. Now, what are the genes involved here? So these genes are a little bit different. And again, you don't need to remember the whole list here, but the theme I want to leave you with is that these are the most common genes, and these genes encode proteins in the desmosome. So I kind of tell patients the desmosome is the cellular glue that keeps the cardiac myocytes together. And so essentially you have this complex in one cardiomyocyte and then this complex in the other cardiomyocyte adjacent to it, and then they actually interact and connect. And if you disrupt this with these genetic variants, then for reasons that we haven't fully worked out, you end up developing this kind of phenotype in the right ventricle, but it can also be in the left ventricle or biventricular. So there's this heterogeneity of clinical presentation. And that's partly why there's this controversy about what the appropriate nomenclature should be. There are a set of diagnostic criteria, which I'm not going to go through now, but there's a set of major and minor criteria that you have to put together to see if a patient satisfies the criteria for ARVC. And this is where it gets really tough to make a definitive decision sometimes as to diagnosis. So who gets an ICD? Generally, anybody who has a risk of 10% or higher of sudden death on a calculator that I'll show you in a minute should get an ICD. And certainly risk factors like history of arrest or impaired either right ventricular or left ventricular systolic function. These are class 1 indications. Class 2 indications include syncope, documented VT, or sort of intermediate drop in systolic function of the right or left ventricles. There is a risk calculator where you plug in a number of things like age, sex, number of inverted T waves on the ECG, number of PVCs, documented VT, and systolic function of the right ventricle. And the calculator will spit out a number that will be the risk of sudden death in 1 year, 3 years, 5 years. So you kind of put it all together, and then that may help you decide whether a patient needs an ICD. Generally, these patients are at higher risk. So your threshold will be probably a little lower to offer an ICD. There are some guidelines that have come out. Jeff Tobin led that team, and this is kind of a flow chart that you can use to kind of decide. Basically, it's kind of what I already told you, who might actually need an ICD. Let's skip through this part here. So exercise is another issue. So this is one of the disorders where we are kind of wary about exercise. There are animal and human data suggesting that exercise can accelerate the progression of disease. So this is one of those situations where the American societies have actually said that you should limit your activity to class 1A sports only. The European Society has been a little bit more liberal, and they kind of say that patients can probably do some more exercise if they're not high risk. But given the fact that any exercise seems to accelerate the disease progression, I'm not sure I agree with the European guidelines in this case. So this is one of those rare situations where you have to be fairly definitive and say, patients have to limit their physical activity. For anticoagulation, if they have had atrial fibrillation, they probably should be anticoagulated. Obviously, if they have a thrombus in their ventricles or if they have a history of thromboembolism, then they should be anticoagulated. All right, so these are some of the cardiomyopathies I wanted to discuss. Let's just talk quickly about some of the neuromuscular disorders. Myotonic dystrophy is one that you may get a lot of referrals for. There's two classes, type 1 and type 2. Type 1 is more has more likelihood of cardiac involvement, but both type 1 and type 2 can. The manifestation of cardiac problems can be up to 90% in type 1, about 20% in type 2. What are the different manifestations? So this is for type 1. Conduction system disease is the most common problem, and that's why patients might be referred to you. But again, atrial arrhythmias, heart failure, and then ventricular arrhythmias, and sort of lowering, decreasing order of frequency. This is what happens histologically. This is from an autopsy series from a few decades ago. You get scar and fat tissue that is infiltrating into the myocardium, but also specifically into the sinoatrial node, the AV node, the bundle branches. So this is why these patients are just at high risk of conduction abnormalities, and they're unpredictable too. So they may have a normal ECG one day and be in complete heart block the next day. It's a very tricky situation. So the recommendations for pacemakers are currently, class 1, anybody with a secondary AV block of any kind, third-degree AV block, or an HV interval of more than 70 milliseconds. Then there's this kind of intermediate area, class 2B, PR interval that's greater than 240, pure restoration that's more than 120, or evidence of a vesicular block. So what do you do there? This is kind of a flow chart that we use. If you're at high risk, you get a pacemaker, or if it's indicated, a defibrillator. If you're at low risk, you just continue to follow patients. But if you're in this intermediate area, what do? One option is to do an EP study, and I'll show you a clinical trial on this in a minute. You could do a loop recorder, put a loop recorder in and just follow them. And then if there's evidence of long pauses, blocks, then go ahead and offer a pacemaker. You could also do a cardiac MRI and look to see what the burden of scar is in the ventricles. And if there's a high burden, it's more likely that they will progress quickly towards a block. These can be kind of tiebreakers that can help you decide somebody who's on intermediate risk, whether they should get an ICD or not. So there was actually a clinical trial about a decade ago looking at these patients that were kind of intermediate risk. Their criteria were a little bit different from what I showed you, but basically intermediate risk patients. And then about 70% of them underwent an EP study, about 30% of them just followed non-invasively, and then got a pacemaker when there was an indication for a pacemaker. The others underwent EP studies, and then if they had a prolonged HV interval, they got a pacemaker. If they had inducible VT on the EP study, they got an ICD. If the HV interval was less than 70 milliseconds and they were not inducible, then they were just followed. And it does turn out that actually the invasive strategy was slightly better in terms of survival and in terms of sudden death than the non-invasive strategy. So, an EP study in this situation actually may be potentially helpful. This is just an illustration of the fibrosis that you can see on cardiac MRI, in this case in a patient with type 2 myotonic dystrophy. Now, what do you do in terms of patients that have atrial fibrillation? In this case, you do kind of follow the CHA2DS2-VASc scoring system. The problem is that these patients have skeletal muscle problems, and they're at high risk of falls. So it becomes an issue of balancing these different risks. And it's something we struggle with all the time. There's no clear answer to this. We do sometimes consider a Watchman device in these patients. Again, there's obviously no clinical trial data on this, but in patients that we think are at high risk of strokes and also, falling all the time, this may be an option that you could offer. Ventricular arrhythmias are less common, but can occur in myotonic dystrophy, and basically the guidelines are the same as they are for other disorders. If a patient has likelihood of a reasonable quality of life and survival for more than 1 year, and potentially, if they need a pacemaker anyway, then an ICD may be appropriate if they are also at risk of sudden death from arrhythmic etiologies. And generally, we do prefer a transvenous dual chamber device if they need an ICD for the pacing function, because these patients are at high risk of conduction abnormalities. And again, because you may have a lot of ventricular pacing, you may want to put in a biventricular device right at the beginning for CRT. All right, and I'm going to finish up with muscular dystrophies. And we have Duchenne and Becker muscular dystrophies as the sort of the two common ones. What happens with Duchenne muscular dystrophy, which is an excellent disorder, is that there's a rapid progression of fibrosis in the heart that leads to heart failure very quickly. The mean age at which you can see fibrosis in these boys is about 13 to 15 years, but about a fifth of patients actually have it even before the age of 10 years, so very, very early on. Not EP related, but we actually put patients on heart failure medications very early in life for this reason, even before there's evidence of fibrosis. This is just the illustration of the fibrosis you see in the myocardium. It's quite substantial. And this kind of just repeats what I told you, that for Duchenne, there's pretty early onset of heart failure or cardiac manifestations. For Becker, which is milder, usually the onset of disease is around the third to fourth decade of life in the heart. But both lead to heart failure, which is often the cause of death nowadays. Kind of probably skip over this, but there's some sort of classical electrocardiographic findings you find in these patients. These are the different genes that are involved in the different neuromuscular diseases that can cause cardiac problems. And again, it's kind of a broad range, but a lot of them are basically dystroglycan complex genes that are sitting on the cell surface and sort of connecting the cytoskeleton with the extracellular matrix. This is actually from Brian Feingold's guidelines, where you have a list of the different genes that cause neuromuscular disease and can cause cardiac problems. You'll see that many of them are associated with dilated cardiomyopathy phenotype. So your treatment will be similar to what you do for dilated cardiomyopathy. And in general, arrhythmias are associated with dilated cardiomyopathy. So if a particular gene is likely to lead to dilated cardiomyopathy, it's also more likely to be associated with arrhythmias, for which you might have to consider ICDs. Conduction abnormalities generally are less common, but they do occur in certain genes, especially amarin and some of the sarcoglycans. One thing I mentioned, so it's an X-linked disorders. So women are carriers. They don't have disease per se at the beginning, but they're actually not normal. They actually, if you look carefully enough, for Duchenne, actually 65% of women who are carriers will have abnormal cardiac MRIs, and a fifth of them actually will have an EF of less than 55%. So even in these patients, you may have to have a look at them to see if there are any problems that have to be managed. So pacemakers generally just follow the general guidelines. The only additional considerations are that for a couple of these genes that are at high risk of conduction abnormalities, you would probably put in a pacemaker and or an ICD if their PR is more than 240 or they have a left bundle branch block. And for current SARE, which is another high risk sort of syndrome, any second degree AV block, third degree block, or HV, interval being more than 70 milliseconds, or a bifascicular block, they're all indications for a pacemaker. For ICDs, there's not anything that is particularly different from most other disorders, but the critical thing is, you want to look at what their likelihood of survival more than 1 year is and their meaningful quality of life. And so it's a shared decision as to whether you offer an ICD to a patient or not. There are going to be some new guidelines coming out specifically for this population later this year, so stay tuned for that. Okay, we have a few minutes left, so I'm going to finish up. I think Dr. Lennon's talked about molecular genetic testing in general, so I'm not going to talk too much about it, just give you a couple of things that are specific for cardiomyopathies. One is that genetic testing can help make the diagnosis when you're not sure. It helps in screening other family members who may not have clinical evidence of disease, and in some situations like ARVC, if they have a genetic variant, you may suggest that they not engage in super competitive sports because they are actually at high risk. Phenocopies of HCM, we discussed, one of them is Fabry disease, and there are some diseases that look like HCM and actually have treatments, like enzyme replacement therapy, and so you don't want to miss those diseases and confuse them with HCM. So that's another reason to do genetic testing. And some of these, many of these patients are young, they're planning families. You can actually, if you identify a genetic variant, you can actually use that information for pre-implantation genetic diagnosis to prevent the next generation from inheriting that genetic variant. The success rate for genetic testing is sort of intermediate. in HCM, about half of patients, we will actually find a pathogenic variant, a disease-causing mutation. For the other cardiomyopathies, it's somewhere between 30 and 50%. So it's not great, and patients have to be aware that you may do genetic testing and may not find a causative disease-causing mutation. That does not mean they don't have the disease. They have the disease, but there's a variety of reasons why we may not have identified a genetic variant. One is that there may be other genes that can cause the same disease that we are not yet aware of, and so we don't actually sequence. There are some options in families that have multiple people with the same disease. If regular genetic testing for specific genes does not find a variant, you can do whole exome sequencing, where you just sequence the coding sequence of all 20,000 genes, or you can do even whole genome sequencing. This is not yet clinically available, but probably will be pretty soon. Whole exome sequencing is clinically available. So it's easy to do, and it's not that expensive. The problem is that we all have hundreds of thousands of genetic variants that are just normal. So we will get lots of variants when we do this kind of testing, and then we have to figure out which, if any of them, is actually disease causing. So on the back end, the interpretation of the data is kind of hard. But these are certainly options if regular genetic testing fails to identify a variant. We talked about how frequently we screen patients with HCM, or at least in families with HCM. What about dilated? What about the other cardiomyopathies like dilated, arrhythmogenic, and LVNC? If you don't have any genetic information, if you did genetic testing, didn't find a variant in that family, or it's just not available, then you should screen them every 3 to 5 years if they're at risk of having the cardiomyopathy. If you've identified a pathogenic variant in the family and your patient has it, but initially they don't have any evidence of disease, then after your initial clinical screen, then every 1 to 3 years, but generally, for me, it's most of the time it's every year. If they have a genetic variant but don't have clinical evidence of disease, they need to get rescreened every 1 to 3 years. For me, it's usually about every 1 year. How about the neuromuscular disorders? Well, for Duchenne and Becker, basically, if under 10 years of age, you evaluate them initially on diagnosis, and if there's no abnormalities, then just every 2 years after that, until they hit your 10 years of age, then they have to be evaluated every single year. And then, of course, if they have symptoms or have cardiac manifestations, then they need to be reevaluated more frequently. And then for female carriers, you probably need to screen them for cardiac issues in their 2nd or 3rd decade of life. And then if everything looks good at that point, then we screen them every 3 to 5 years thereafter. All right, and I'm just going to finish. So this was a scientific statement that I shared a couple of years ago, talking about what we need if we have when we set up a cardiovascular genetics clinical program. I just want to say that one of the things that we emphasize, that it's a very much of a multidisciplinary approach with multiple professionals of different disciplines, and electrophysiology is extremely important here, and we need electrophysiological expertise on the team. And Dr. Zingman knows very well, we usually have Friday clinics together, so I'm sending her patients almost every single week. All right, so in summary then, risk stratification for cardiomyopathies for sudden death has been individualized based on their personal history of syncope, any documented ventricular arrhythmias, structural and functional abnormalities on imaging, family history, and then in some cases, the genetic etiology will also guide you. The CHADS VAS score is relevant in most cases, but not applicable in HCM. And permanent pacemakers are frequently required in especially in type 1 myotonic dystrophy, Emery-Dreifuss, and Laminase C muscular dystrophies. And this is a niche population, but in HCM patients following septal reduction therapy, many of them end up needing pacemakers. And so with that, I guess I ended on basically on time. We have a few minutes left for questions.
There are a few questions in the chat.
Right. In the chat box, yeah. Okay.
Yes.
So when you see a patient who appears to have hypertrophic cardiomyopathy by echo, what workup goes into differentiating these different types of cardiomyopathies, which may look similar in echo. Absolutely, very important question. So we actually do cardiac MRIs on but everybody, unless they have devices in already. So that can sometimes distinguish the infiltrative cardiomyopathies from regular hypertrophic cardiomyopathy. Genetic testing can help, of course. Many of these phenocopies or mimickers of HCM, you have pretty high likelihood of finding a genetic variant for those. So if there's any suspicion, for example, PRKG2, it's on the HCM panel. All these mimickers are on the gene panels for HCM. And so if a patient has one of those other mimickers, there's a high likelihood that the genetic testing will pick it up. And then for some of these disorders, you can actually do enzyme assays to see what the enzymatic activity is. So these are biochemical assays that can be sent off. So that may help as well. So usually these are some of the ways we can start distinguishing these different disorders. There's softer things. Sometimes the pattern of hypertrophy looks a little different. Many of these infiltrative disorders will have sort of more classical, different electrocardiographic abnormalities. I mentioned pre-excitation, for example. So that might help, but you can't make a definitive diagnosis that way. But I think at least in your level of suspicion is higher that you may not be dealing with regular subprimary HCM. All right. Another question is, how do you talk to affected patients about their families who should be screened? How are potentially affected family members approached? Yeah, so this is a very challenging problem because we are bound by HIPAA in the United States, and we cannot directly contact relatives of our patients. What we do is, all our patients will get genetic counseling unless they've already had it. We wait for all the clinical tests to be done. We wait for the genetic test result to come back. And then we have basically a template of different letters that, depending on the situation, whether there's clinical evidence of disease, whether a genetic variant was identified or not, we put it together, personalize it for that patient. We give a copy of that letter. It's a family letter that we give to the patient, and the patient then has to basically give a copy of that letter to their relatives, first degree, second degree, even third degree relatives. How often does that happen? It's completely beyond our control. I don't think it happens enough. And that's a challenge. There are efforts underway. There's some research going on here as well, and other institutions, looking at other ways like using apps or Facebook sort of methods to share data that the patient can share with their relatives, and make it a little easier than a hard copy letter. So that can potentially help. There's some other jurisdictions around the world where actually clinicians are allowed to talk to relatives directly. So they have a different way of doing it, and I guess it's a balance. Obviously, we balance that patient's privacy with the risk of really adverse outcomes in relatives that are undiagnosed. So I don't know nobody has the right answer, the right balance, but this is what we do in the United States because we cannot directly speak with any relatives.
Okay, I'm actually back here. Thank you, Dr. Ahmad. That was fantastic. I see that we don't have any more questions in the chat right now, but if people do have questions that they think of later that they didn't have a chance to type into the chat, go ahead and contact me or the coordinators, Randy Burt, or your physician liaison, and we'll get those questions to Dr. Ahmad so he can reply to you. Thank you very much for a great talk.
Great. My pleasure. Thanks again.